Good morning. I know it's early, but good morning. There we go. I'm super excited to be here, and you all look fantastic. It's so early. I'm not accustomed to starting meetings this early, but I just wanted to say thank you on behalf of the American Heart Association for allowing us to be here and share with you today. We are super excited because we're addressing a group of individuals who have a long-standing history of taking care of people and serving people. And it's such an honor to be here to serve you today by bringing some valuable information. So please enjoy and thank you.
I'd like to thank the National Black Nurses Association for this opportunity to speak today, as well as the American Heart Association. So today we're going to talk about the clinical assessment of peripheral arterial disease. And our goal today is to identify patients with peripheral arterial disease and apply the American Heart Association ACC guidelines for screening and management of peripheral arterial disease. And I would like to have a show of hands. Are there nurse practitioners or physician assistants here? Good, okay. And by show of hands, how many people work with vascular patients or cardiovascular patients? Okay, so a fair amount. Good, okay. All right, so why are we here at 6:30 in the morning talking about this topic? It has a huge impact. So worldwide, the prevalence is 200 million, and of that 200 million, 8.5 million are here in the United States. And it's the leading cause of amputations as well. Now, the awareness of PAD has increased, but 1 in 4 people don't know the risk factors for peripheral arterial disease, nor that it can lead to amputation. And then once you get diagnosed with PAD, 1 in 7 don't even know that peripheral arterial disease can lead to amputation. And then there are some discrepancies with ethnicity. So blacks and Hispanics have a higher increase of amputation, and PAD is more prevalent in patients with diabetes, smokers, and those with CKD. All right, so what's the importance of early detection? So peripheral arterial disease is caused by atherosclerosis, and that's the blockage of the artery by cholesterol, protein, and cells, so the platelet cells. If you detect it early, you can prevent other disease. So for instance, the lower extremity disease, it's the arteries that are blocked are the iliac arteries, the femoral arteries, popliteal or tibial arteries. But it's a systemic disease, so therefore it affects all of your arteries. So not only do you have blockages in the legs, but you can have coronary artery blockages, carotid blockages, renal artery blockages, and you can have aneurysms as well. And then peripheral arterial disease also carries, because it's a systemic process, can lead to higher stroke or heart attack risk and reduce quality of life. So what are the early signs of peripheral arterial disease? Now, there are several levels of disease, and we're just going to focus on the lower extremities. So some people, I know you have all these patients at home, they don't walk much, so they don't experience any symptoms because of the lack of activity. And that could be because they have an arthritic problem or a back problem, but they never elicit any symptoms. So those are the asymptomatic patients that have PAD. And then you have patients that have claudication, and this is the most common symptom that you'll have. So at rest, they don't have any symptoms, but they go to start to walk, and they can't walk because their muscle doesn't have enough blood supply, and you might hear them describe symptoms of either cramping, pain, fatigue, weakness in those muscles. And that goes away with rest, but it's always there when you're exercising because your muscle, as you're exercising, needs more blood supply. So the baseline perfusion is good, but when you exercise, you need to increase that blood flow. And when there's a stenosis in your artery, it does not accommodate that. And generally, about 25% of people that have claudication go on to have the next level, which is a more severe level of arterial disease. So the next level is called critical limb ischemia, where at baseline, they're not getting enough blood flow to their muscles or their nerves, so now they have pain at rest. So when their legs are level with their body at night, the nerves don't get enough blood supply. And you'll have patients say, I ended up swinging my legs over the side of the bed because my feet felt better. And that's because gravity is giving them the increased perfusion to the nerves, and that's causing less pain in their feet. And then the last one is actually critical limb ischemia, I should say, not only rest pain, but you can get ulcers or gangrene. So those are the things that you look for when patients are describing their history of their problems. And then the last, but not least, is acute limb ischemia, which means that they have vascular disease on top of a very acute event. So it's caused by a clot that obstructs an already narrowed artery, and they have a profound obstruction to their leg, and they have rapid onset of symptoms. So there are 5 Ps, and you may remember this when in nursing school. So it's pallor, poikilothermia, which is feeling cold, paralysis, paresthesias, which is numbness and tingling, or pain. That's the most important one, because pain occurs when you don't get enough blood supply to the nerve. So the 5 Ps are indicative of acute onset of blood flow blockage in the legs. So the risk factors for PAD, and this is according to the American Heart Association, American College of Cardiology guidelines. So anybody 65 or over are at risk for PAD. So any of those patients, you want to screen them for that. And so if you have, you look at the risk factors. So the risk factors are smoking, diabetes, high cholesterol, or high blood pressure. So smokers have twice the risk of PAD of non-smokers. Now, if you have diabetes, you have a 1.7 increased risk of having peripheral arterial disease. And diabetics, if their A1C, the measurement of that glucose over a 3-month period, is 6.5 or greater, then they have a higher risk of amputation. If it's lower than that, then their risk of amputation is reduced. And other conditions, so if they're 50 to 64 years of age, with one of those risk factors, diabetes, high blood pressure, smoking, or high cholesterol, or a family history, they're going to be at risk. So they're equal to the 65 or older group with those conditions. If you're less than 50 and have diabetes and then one additional cardiovascular risk factor, the hypertension, smoking, or cholesterol, then you also are at risk. So the various age groups with those risk factors increase your chance of having peripheral arterial disease. And lastly, to circle back to the systemic nature of peripheral arterial disease, if they have coronary disease, if they have carotid blockages, if they have renal artery stenosis, those people are at increased risk for peripheral arterial disease as well. So we put together some steps to help you remember. So we're going to go over this. These are the people that need to be screened for vascular disease. So again, age greater than or equal to 65, age 50 to 64 years with those atherosclerotic risk factors, age less than 50 with diabetes and one additional risk factor, and then patients with known vascular disease and other beds. The next step is to, when you're taking the history, what are the red flags on those patients that they tell you about? So claudication is that exertional symptom where the leg is fatigued, cramped, or painful when they're walking that stops when they stop walking. If they have other non-joint related exertional symptoms, if they can't walk very far because of these symptoms, or if they now have pain at rest, they can't sleep, they're dangling their feet over the side of the bed, or they get a sore that's not healing, or they have gangrene. So what are the red flags on physical examination? So first and foremost, you want to check their pulses to see if there's any vascular pulses. Now, we don't have a leg on this one, but you're basically going to check the femoral, the popliteal, and on the foot, there's a DP and PT pulse. Now, do you all know what a bruit is, a vascular bruit? Raise of hands. Anybody know what a bruit is? Okay. So it's a reflection of turbulence in the blood flow that's created when there's narrowing in the artery or a tortuous artery. And so you hear that with your stethoscope. So it's very important to listen for that because that's also an indication of peripheral arterial disease. And then if they have a non-healing wound, say they got a brand new pair of shoes and this blister created on their foot, it doesn't heal, that's another sign. Clearly gangrene is a pretty obvious sign. But other things that are suggestive of peripheral arterial disease, have you ever seen someone that has a really shiny leg and it looks like they shaved their legs? It's because they lack blood flow to their skin, so they lose that hair, and therefore it's really shiny. So that's one sign. And then patients have really trophic nails, so buildup of really thick nails, that's another sign because there's lack of blood supply. And then a very subtle finding is there's a loss of any fat pads on their toes. So you can press on their toes and they collapse. There's nothing in there. There's no meat to their toes. It's all collapsed because it's just covered with skin. So that's another finding. So how do you find out if they have any bad pulses or sores on their feet? You got to take their shoes off, right? Because if you don't take their shoes off, you don't know that. And some people are embarrassed by that. They don't want to show you their feet. So you have to take their shoes off in order to feel the pulses and then to ascertain whether there's any change in the skin. Some diabetics have calluses that can lead to sores. Other people have a foot infection. They don't realize it. They were trimming their nails and they clipped their skin and they got an infection from that. So you can see if there's an infection, which is another indication. If it's not healing, then you need increased perfusion to their blood flow. And then if there's any change in the color of the skin, so if they've had any pallor there, or if there's mottling or redness, that also helps. And one of the signs that you can see on physical exam when patients, and I know you've all seen this, when you have patients sitting in a chair, their feet get really red and rubrous looking, that means the purplish red color, and then they elevate them and they get white. So that's one of the clinical signs. It's called dependent rubor and elevation pallor. So that's a really simple test, and you can see it in a lot of patients and before they elicit symptoms. All right. And so the guidelines tell us that if you are at increased risk for PAD, and the table means all of those risk factors, so 65 or older, those other risk factors with the ages, with the diabetes, and then they need a good physical exam and auscultation of bruits and inspection of the feet. All right, so once you find a patient that has a really strong history of peripheral arterial disease, you have some physical findings that are suggestive of that, then you want to go on to the testing of that. And so I'm going to go on talk about the ABI next session, but physiological testing, and this is in the vascular lab, and this is called a pulse volume recording. You're essentially putting blood pressures at certain intervals along the leg, and you're measuring the difference in those blood pressures between those cuffs. And if there's a significant drop between one cuff to the next, that's where the blockage is in the artery. And then the blood pressure itself is important as well. And you see these little blood pressure cuffs on the toes. When you have diabetes, these blood vessels here get calcified in the medial part of the artery, so they don't compress. You know, normally when you take a blood pressure, you obstruct the artery and then let it go. The same thing happens with this, and then when they have calcifications, those blood pressures, those arteries don't collapse, and so you can't get a good blood pressure on that. So this is a toe pressure, which is not affected by that calcification, and I'll go into that in a bit. And then look at anatomic imaging, so you do ultrasounds. If you suspect that there's vascular disease, you do an ultrasound of that leg, and you can determine that level of blockage. And it's important to do an ultrasound because you can minimize contrast if you have to do a further study like an arteriogram, or a CT scan is another anatomic imaging test. And then once you figure out if they have vascular disease, then that opens up the door to possibility for other disease, like coronary artery disease, carotid disease, or aneurysms as well. So an ankle brachial index is also abbreviated ABI, is the cornerstone of diagnosing PAD, and it means that if there's a difference in the ankle and the arm pressure, then there's a significant stenosis. So what that means is ankle pressures are usually equal to or greater than the pressures in your arms, and therefore if you do a ratio, you can see the difference. So normally you want the patient to be lying down for at least 5 minutes and relaxing in a supine position. You do Doppler pressures both on the ankle, so you're going to get that DP pulse here, DP pulse here, posterior tibial pulse here, and then you do arm pressures with the Doppler because the Doppler is more sensitive than the stethoscope, less, chance of error with interpretation with the stethoscope. And then you take the higher of the two arm pressures as your denominator, and then your ankle pressure, you take the higher of either the posterior tibial or dorsalis pedis pulse as your numerator, and then you get the ratio. So what's significant? So if normal, it should be over 0.9. Anything under 0.9 or under, that's significant for peripheral arterial disease. So that means that that ankle pressure should be higher, but it's not, it's lower than. And then if you have that tibial artery calcification, in those diabetics, because it doesn't compress, guess what? That blood pressure is going to be high. So that's the flaw of doing ABIs in diabetics. But if you put that blood pressure cuff on the toe, then you can get a toe brachial indice, and that'll also diagnose peripheral arterial disease. So a lot of patients at rest can have pulses, just like we mentioned before. If they're not exerting themselves, they have perfusion that's sufficient to not cause symptoms. But if you exert yourself, then they're going to have symptoms. So what you do, if the patient has a normal pulse at rest, you want to exercise them. So what we do is get blood pressures at rest, like this, and then we get them on a treadmill, and we walk them until they can't walk anymore. When they get that symptom in their leg that causes them to stop, we repeat that. And you're going to see a lot of people have normal blood pressures at rest, but they drop with exercise, and that's indicative, and that's important to do, especially if you have a patient that says, I get these symptoms when I walk, but I don't have any pain when I don't walk. And so that's what you want to do, a resting and exercise ABI. So that's another important distinguishing fact. And so this is a myth. Diagnosing PAD doesn't change the patient's medical management, but it does. And so what you want to do is it uncovers other cardiovascular problems they could have. And then it also leads you to then the treatment of that. So you want to first, when you diagnose the patient, you want to make sure they're aware of what the disease process is. You want to explain that so you they buy into your recommendations in medical management. But there are also medicines that can help. And I think we have a handout on that. We have some. You want to put them on antiplatelet medications. So if they've got a diagnosis of PAD just by the blood pressure or the ABI, then you want to start them on a antiplatelet agents such as aspirin. If they definitely are symptomatic with vascular disease, you want to put them on an antiplatelet because if they're symptomatic, it'll reduce the risk of stroke, heart attack, and death if they have symptoms of PAD. So it's a very important drug. Aspirin in particular, it's an old drug, but it's very important. And then statins, cholesterol medications should be started on all patients with PAD. And then if they have high blood pressure as well as their vascular disease, they should be started on an ACE inhibitor or an ARB because that will decrease their risk of stroke, heart attack, heart failure, and death. So those are all data that supports these recommendations. When you first have a patient that has vascular disease, you first want to talk about lifestyle modifications. So these medications in particular, and then you want to manage their risk factors. So if they're diabetic, optimize that A1C. If their blood pressure is elevated, you want to get that down below 130/80. If they're smoking, of course, that's one of the biggest things because remember, there are increased risk of that. And keep in mind, if you have the smoking plus diabetes, that increases your risk of vascular disease by 3 to 4 times. So combination of those two you see a lot of. And then when patients have any revascularization procedures, they call a dual antiplatelet therapy, which means aspirin plus another antiplatelet, for instance, like Plavix or like Effient or ticagrelor or other antiplatelet medications. They usually have those two medications taken simultaneously for at least 3 months after a revascularization procedure to keep the artery open. And then you want to talk about, there's another medicine that can be used if you have claudication. So claudication can be improved by adding a medication called cilostazol or Platol. It is a phosphodiesterase inhibitor. Essentially, it makes the arteries get a little bit bigger, they dilate. And so that patients, once they start a walking program, it takes about 6 weeks, but they're going to see that their walking distance improves. They can walk further before those claudication symptoms start. So that's a very good drug. The downside of cilostazol is that it does make your body retain some fluid, so it shouldn't be used in anybody that has heart failure because it'll make them retain fluid. So lifestyle modifications, in addition to medications, you want to do a heart-healthy diet, so the NASH diet, so low cholesterol, low salt, and then you want to have them lose weight because that'll optimize their risk factors. So especially most people in America have just eat a little too much, and then, so their weight is up, and that will help both the diabetes and blood pressure control, and then smoking cessation for sure, and then regular exercise. So studies have shown that supervised exercise really will help patients to improve their walking distance, improve their risk factors, improve their cardiac conditioning. So all of that is very good. Now, the Centers for Medicare and Medicaid have approved payment for vascular rehab now. A lot of facilities are doing that. I have to say Duke is still working on their part of it, so we haven't started in our facility, but it's going to be a very important part of risk factor management on patients. And you should always offer a supervised exercise prior to suggesting revascularization. So revascularization can include catheter-based procedures where they go in like they do heart catheterizations. They open up the artery, they open it with the balloon, and some places they put stents. And then they can do it in combination with bypass. So some people have such a long occluded artery that they cannot open that because it's pretty calcified and hard. So they'll do a bypass around that blocked artery. So typically you're going to see the most common area for blockages in the thighs. So patients will get calf claudication. And so if they cannot, with medical management, improve their walking distance and they're limited by that, then the bypass from above and below that blocked artery will improve that blood supply. And then other medicines that people might try to use, like blood anticoagulants. And the anticoagulants have not shown benefit to reducing cardiovascular risk. Other medications that people might try, have you ever heard of hyperhomocystinemia? It's a risk factor it's a protein that's in prevalence is elevated that can be lowered with B12 vitamins, but studies have shown that that was initially thought to be a risk factor, and that's not helpful, taking B vitamins. And then chelation therapy, anybody heard of chelation? That too has no good evidence. And then Trentol, has anybody ever used Trentol for vascular disease? That has very weak evidence to be used for vascular patients. So primarily the cilostazol is a good medicine, but not the Trentol. All right, so when we have peripheral arterial disease, then you have a 3 to 4 times greater risk of heart attack, stroke, or death. So that's why this is significant. So you can have chronic kidney disease because it's, again, a systemic process, gangrene, limb loss, and death. And then approximately in 2015, 13,000 deaths were associated with peripheral arterial disease. So what is your role? So if you understand the risk factors, if you understand how to detect peripheral arterial disease, you can prevent people from going on to having these kind of complications. And then, again, you want to buy in with the patient. You want to make sure they understand what's going on with their body, and you want to talk to their level. So a lot of people don't have a elevated education level. Most people understand at the 6th grade level, so you want to make sure they understand the terminology. Atherosclerosis is such a big word. If you boil it down to them, they're going to understand, they're going to buy into your recommendations, and that therefore improve their health as a result. And then you want to involve all of their healthcare providers. So we've noticed that with the electronic medical records these days, it's easier to communicate. So we communicate both with the primary care providers, the endocrinologists, the nephrologists. All of them help us optimize those risk factors for the patients. And it's important because every time a patient sees a provider, for instance, if they're a smoker, they're going to be told, you really need to stop smoking. This is going to prolong your life. And so if you have buy-in from all the providers, it's going to hit home for the patients a lot more. And so bottom line is you want to detect it early because you're going to prevent not only amputations or other risk factors of losing limb loss, you can prevent cardiac disease. And there's a lot of patients that don't even know they have coronary artery disease until you start uncovering symptoms. So it's just think of it as a systemic process because that's going to help keep these people from getting complications such as kidney failure or heart attack or limb loss. All right, so great resource is the American Heart Association. You can check this out. It's like a 23 or 24 page, but it's interactive. We've got a lot of drop-down features to it that you can print it out if you want to, but it's very helpful for a clinician's tool for peripheral arterial disease. Other resources, you can go to the Society for Vascular Nursing has patient education booklets. You can download those for free. There's sources on the Vascular Med, which is a vascular surgery website. Those are also very helpful for patients. And it talks even about revascularization procedures. Those are really helpful. All right, so to tie this together, it's always helpful to have a case study. So you can gather all the information that we just talked about and apply it to a real situation. So we're going to talk about FD. FD was a Hispanic male. He was diagnosed with diabetes at age 26, and he was started on glucophage, but no insulin. And then at age 34, he switched doctors and he started using insulin. And this is on a new endocrinologist order. And then metformin was also added to his treatment in 2006. He underwent surgery abruptly. He had symptoms of pain, weakness in his foot, paresthesias. So what does that make you think of while we're talking about that? And we talked about the levels of peripheral arterial disease. Does anything, we have asymptomatic, we have symptomatic or claudication, we had critical limb ischemia or acute limb ischemia. Which of those categories would you say that his symptoms fell in? If he had abrupt onset, paresthesias, pain, it was cold, and he couldn't move his foot? Anybody? Acute limb ischemia, right, because it's abrupt occlusion of that artery. So he had an operation to open up that artery, but what happens when you have lack of blood supply to an artery and then you open up a full head of blood supply, then it swells. You can get compartment syndrome. I know you've got, how many people have seen compartment syndrome? It's a pretty devastating complication. So the tissues swell, and the muscles are all in a fascia. It's a tight layer, and if it's not relieved, it can compress arteries, muscles, and the nerves, and you can lose tissue. So the fasciotomies are incisions made on either side of the tibia that relieve the pressure and then let that pressure come down. So this FD did experience this, and he went on to have had to have a wound vac in order to heal them and a skin graft. And then after that, the next year was full of surveillance of this leg. He had ultrasounds, Doppler angiograms, bypasses, and ultimately his foot was swollen. So just refreshing those risk factors. So he was between 50 and 64. He's Hispanic. He had diabetes. He did smoke for less than a year, but all of those risk factors made him, should have been one that was screened for peripheral arterial disease, and he wasn't. It wasn't until afterwards. And then he continued to have trouble walking. He didn't have pain at rest, but he couldn't walk. He couldn't function. So he was told about this peripheral arterial disease and his surgical options, and the vascular surgeon, and he decided that because he was so limited by his leg pain and he couldn't function, that he went on to having amputation. And so that's what we're saying. This is something that could have been prevented had it been picked up early. And this is the whole purpose of this talk today, just to try to help prevent this and screen it early. And so he left the hospital January 10th without his right leg below the knee. Again, diabetes, he had that blood clot, that acute limb ischemia, former smoker. These are the medications he was on. And then this is one of the pulse volume recordings. So on the your left side, these are normal waveforms, but you can see the waveforms are dampened on this side if you compare the two. And that's what these blood pressures that were the cuffs here, that tells the difference. And that showed reduced perfusion. And actually, if you listen, anybody use a Doppler in their business? So if you listen, you can hear the normal artery sound is triphasic. As you get blockages, it becomes biphasic, so you just hear two sounds. And then when it's really stenotic, it becomes monophasic, so you hear this shh kind of sound. It doesn't have any waveform variation. So next time you play with the Doppler, listen for that, because I usually use it on my artery, and you can tell the difference between a good artery and then a patient that has decreased perfusion. All right. So what better than a case study is to give you the actual patient. So I'd like to introduce Frank Diaz. He's going to tell you about his story, and this is the one we just gave you. So I think we can learn a lot from patients. So I'd like to welcome Frank to the podium here.
Thank you very much, Debbie. Good morning, everyone. Buenos dias. We're still together here. All right. So I'm driving home from work on a Tuesday morning in December in Chicago, where I'm from. And all of a sudden, I'm driving along, trying to get home, and I noticed my right foot stopped working. My ankle wouldn't flex, so I couldn't work the pedals in the middle of traffic. And so luckily, I had to turn to my left foot. If you've ever tried driving with your left foot, there's a trick to it. So all of a sudden, I find myself using my left foot. I made it home safely, so it's a good ending to that story. But I had trouble actually falling asleep, and the next morning, I told my wife, I'm having trouble with my foot. I think I should call the doctor and see what's going on. And luckily, the doctor made time for me the next day and took my pulse and noticed there was no pulse on my right foot. And luckily, again, he was in his medical office in the building next to the hospital, so we wasted no time in getting me across to the ER and finding out that PAD was involved. Now, living with diabetes for a few decades, I'm pretty sure that I thought I understood what was going on. I was not necessarily the best patient, but certainly careful and somewhat educated on warning signs and what to do in case my blood sugar drops and so on. But PAD came as a total surprise to me. Didn't really have all that information together to connect what was going on with my foot and the complications of diabetes. Okay, I did go through the patient education sessions. I did understand all about the little circle with the red gunk in it and, you know, what it meant. But I didn't quite associate it with hardening of the arteries and blockage. So this was quite a lesson for me. And as you heard earlier, for the next year and a half after that incident, angioplasties, angiograms, Dopplers, bypasses, swelling of the feet, and so on. All of that dominated my daily life. And at times, my foot would improve. So my medical team thought there was some hope and the arteries would clear up and I would once again get some circulation. But that was only temporary because then the arteries once again would give in and weaken. And again, as you heard, I went in for amputation in January of 2017. But my story, unlike others, obviously, has a positive outcome because of the great care and support from my team at St. Joseph Hospital in Chicago. I'm able now to come before you, and I'm able to walk around with the help of a prosthesis and you know, do much better than most cases. Now, this was not the first time that I noticed I was having trouble with my ankle. If you go back, and I realized that I had trouble flexing in other occasions, and for some reason I didn't bring that up to my doctor. So that was definitely something I had to learn to communicate better and let my doctor know that something unusual was happening, even if I wasn't fully understanding of it. But again, hospital stays and surgeries and a lot of visits with the doctors and the nurses helped me get through all of this. So I even, actually, after the amputation in January, I took time to write a letter to my right foot. This was my way of coping, right? We all go on social media and tell the world what's happening. So I put a little breakup letter together on Facebook, and I told everyone, "Dear right foot, I know we've had a great time and all the dancing and the 5Ks and all the running and everything we've done together, but now it's over. It's time to let you go. You're a threat to my health and the rest of me. So I'm sure my left foot will get along fine and we'll do the best we can. But this is it. Love, Frank." Oh, thank you. So that was my way of letting the world know what was going on and how to cope with losing a limb and understanding why and everything that furthered my education in health. So I was motivated, of course, to come back from an amputation and do better for the sake of my wife, who's been by my side all this time, and also because I play guitar, and I don't like to play sitting down. I play guitar standing up all the time. So something as subtle as entertaining myself and others became quite a motivator. And so with a lot of rehab and therapy and help from my prosthesis technicians, I was able to work out a lot and improve my balance and figure out how to make the most out of my situation with PAD and using a prosthesis. As I mentioned, a lot of support from my family and my intent to play with the grandchildren as well, gave me the motivation and the strength to keep going. But I know, and you know as well, not all stories end like this. We don't want this outcome. We want to help people understand what's going on with their blood flow and why their muscles and arteries work the way they do. And so I'm here to urge you to continue reading and understanding PAD better and make sure you and your peers know about those red flags that Debbie mentioned and all the different ways we can alert people to understand arteries and what their jobs is, and give them the opportunity, as I have had, to live a complete life. All right? Thank you very much. Buenos dias.
This has been such a great presentation so far, and to have a live patient here with us makes it so much more memorable, but also that we will actually, you know, when we have, I know in nursing, I know I'm a kinesthetic learner, because when you have the patient and, you know, not just you heard it, but this, we will remember this and be able to provide better care for our patients in the future. So thank you very much for, to all of you for this great presentation. We will definitely remember everything. At this point, I was wondering if we have any questions for the presenters and for our patient, Frank, as well. So for Terry or Deborah or Frank.
Hello, oh sorry. Rakisha Clark with Eastern Oklahoma Black Nurses Association. I wanted a question for Frank. We recently had a men's health forum, and one of the things I talked about was patients needing to communicate their symptoms. And I just wanted to ask you, you say you had the symptoms, you just did not vocalize it to your providers. As providers, what could we do to maybe increase the communication from our patients?
Yeah, sure. I guess it's really a matter of adding all these different warning signs. Again, I refer to understanding the warning signs of diabetes, you know, a blurry vision, frequent urination, and so on. And now we can somewhat find a way to add that to the list. So when the question and answer period comes, you know, with the patient, there's that opportunity to ask, are you feeling this way? Is your extremity responding this way? Are you able to sleep well? What are you doing? And that goes along with all the other symptoms or descriptions.
I think you bring up a good question. One of the things we're trying to do at the American Heart Association is raise awareness, not only with the public, but with our healthcare providers. So sometimes the person doesn't know to ask the questions. To Frank's point, he wasn't really connecting those dots. So what felt like, you know, a pain in the leg or something uncomfortable, it didn't really resonate enough for him to share. And then as a healthcare provider, you've got so many comorbidities, so many things you're checking for, so it may not necessarily be on your radar to ask certain questions. So what we're trying to do is connect those dots. And that's one of the benefits of us even being here, because we need you. We need your help in understanding how do we bring the two together so that the Franks of the world know how to mention certain things or ask certain questions, and then so that you, once you know certain risk factors are involved, can also inquire and pull it out. We need help in putting that together. So that's one of the benefits of the American Heart Association being here, so we can hear from you. So thanks for that.
Good morning and thank you. Veronica Clark-Tasker, Greater Washington, D.C. chapter. Having the Latino background and understanding the culture, how when you look at changing diet, talking about your body image as a male, you know, we got the macho there and you're a grandpapa. How do you handle that in communicating the change in diet to the family, for them to understand the history and that God is still with you? How did you do that?
Good, good. Well, I tend to be somewhat curious by nature, so I'm always going to bring questions to my PCP, my doctor, and my mother always reminds me to bring questions. So there's no way that I'm going to show up and just be quiet and let the doctor do all the talking, or the nurse, or whoever is tending to me. I'm going to be more assertive about what's wrong and a little bit clearer in my description of my symptoms, learning from this episode and trying to tell other people. Don't be shy, don't be bashful about asking or wondering. And take up as much time as you need to be clear and be satisfied with the the medical response.
Thank you.
I have a quick question. You mentioned, Deborah, about the screening from 50 to 65 years old if you have the risk factors. We know how, in terms of reimbursement for care provided by primary care providers, and also, is this an approved screening for providers? Because you know how you can spend all that time with the patient. It's not that as providers we don't want to spend the time with the patients, but not only if we incorporate this one more screening, then how do we get reimbursed, and how is it covered, or has it been approved?
Thanks for the question. So it is approved. As you go over the guidelines, it does tell you that these people are at risk, and therefore the next step is to do the vascular study to confirm that. One thing that the American Heart Association has just put out is this lower extremity guideline, and it really incorporates everything that I just told you about, and it's a nice, easy reference for you. And then it has algorithms in it as well. So this will, I guess, will be at the American Heart Association table. And some of you might have this. I don't think they had enough to pass out today, but this is a very good guide for you. But yes, ABIs are covered, vascular studies are covered, all of that. If the patient has disease, it is covered. Yeah. So, thank you.
Okay, so the question was, with PAD Awareness Month coming up, what is the American Heart Association doing, and how can this group help? PAD Awareness Month is in September, which is right around the corner. And once again, we have the dubious task of raising awareness and making sure that we get as much information out as we possibly can. I think you heard earlier when Deborah was sharing that according to our 2016 guidelines, about 8.5 million adult Americans are affected by PAD, and many are unaware. And that science was actually published in 2016, but that number has almost doubled since, because as the population continues to age, that number will continue to increase. And so there is a great effort that has to go into raising awareness, and we're going to capitalize off of PAD Awareness Month in September. So a few of the things that you're going to see, one, that toolkit. The PAD toolkit is very helpful, interactive toolkit. We're going to be launching that, pushing that out via different, thank you very much, via different social media outlets. We're also going to share some other patient stories. We also have a lot of provider tools that you'll see on the AHA website, specifically in the PAD section of that website. We also are working with great organizations like the Association of Black Cardiologists, the Anticoagulation Forum, and some other strategic partners to do webinars similar to this one. As you know, this one is a live audio taping. It will be an enduring asset, so whatever you missed today, you can go back and listen to it again. But there are going to be other assets available similar to this that you can access and use and look at and hopefully pass along. I think the other thing I'd like to put in a plug, Deborah and I have known each other only a few months. I met her at an event And once I found out she was a nurse and I knew I needed someone to share this information, I asked her and she volunteered, and I'm so grateful for that. But there's always an opportunity for you to work with the American Heart Association to be part of this journey, right? Many of you are very seasoned, have been doing this for quite some time, and there's lots that we as an organization can learn from you as a healthcare professional, especially when we're focused on communities where there's a lot of underserved individuals, right? We want to make sure there's a standard of care that is consistent across all communities and not just based on someone's race or their zip code. And so you can be part of that. So at any point, if you would like to be able to share on a platform similar to this, or if you have ideas or information on how we can better communicate with the public about vascular diseases, peripheral vascular diseases such as PAD and others, please reach out.
And while the mic is making its way to the back, I just want to let you know that people that need the supervised exercise program and have amputations, they may not be able to run on the treadmill. Their studies have shown that arm ergometry, so it's a bicycle with your hand, is sufficient to increase cardiac conditioning and vascular conditioning. So believe it or not, that's something they can use, and that's something that should be used, especially if they're bilateral amputees. So that's the other limitation, so keep that in mind as well.
Please join me in giving a big round of applause to our panel today. You guys did a fabulous job, and I don't think we'll ever forget this presentation. And I'm serious. Thank you so much.